Hello, my name is Dr. Meenakshi Nayar. I'm a consultant in rehabilitation medicine, and today I've got the pleasure of interviewing Dr. Gui Tran, consultant rheumatologist from Harrogate. Thank you for joining us.
Thank you for asking.
So we've got the very interesting topic of rheumatoid arthritis today to cover. So let's start with who gets rheumatoid arthritis.
Well, anyone can get rheumatoid arthritis, even children, but it's most common amongst females and people aged between 30 to 50 is when it commonly presents itself.
Okay, and what are the clinical symptoms that they present with?
Clinical symptoms of rheumatoid arthritis are usually small joints, swollen and tender, so hands and feet, and it tends to spare the DIP joints as well.
So it's the more proximal joints of the hand?
Yes, the more proximals, MCPs, PIPs and wrists.
Okay, and what are the classification criteria for rheumatoid arthritis?
Well, there's a EULAR, EULAR, which stands for European League Against Rheumatism classification criteria, which is predominantly used for research, but can be helpful for people wanting to diagnose rheumatoid arthritis. And that was published in 2016, and it looks at it's a point scoring system, which looks at a combination of different factors, which include the types of joints affected, whether they got rheumatoid factor and anti-CCP, which are proteins in the blood, which can be helped to diagnose rheumatoid arthritis, whether they've got raised CRP or not, and the duration of their swelling.
Okay, so you mentioned anti-CCP and rheumatoid factor. Can you tell us a bit more about the significance of that?
Yeah, so they are proteins, antibodies in the blood, which can be detected even before the onset of rheumatoid arthritis, and they come in different levels, and if there's more than 3 times the upper limit of normal, then it's thought to be a high level. And anti-CCP is thought to be more sensitive and specific than rheumatoid factor in detecting rheumatoid arthritis.
Okay, so other than these autoantibodies, what else would you do in terms of investigations?
We would check for CRP, which is a level of inflammation. Bearing in mind that it can be normal, we would check for full blood count using these and LFTs because that is helpful as a baseline in case we need to start any medications. We can also do, if there's any uncertainty, an ultrasound scan of the hands or the feet, or both, and x-rays of the hands and feet to see if there's any long-term chronic damage.
Okay, and then is there any role for ESR?
There is a role for ESR. That's also raised in people with rheumatoid arthritis. CRP tends to be used more because it's more responsive to treatment, and there are other causes of raised ESR, such as age and BMI, which can raise ESR artificially.
Okay, so you've made the diagnosis of rheumatoid arthritis. What are the treatment options?
So the acute treatment of rheumatoid arthritis includes steroids, because the long-term treatment includes disease-modifying agents. Initially, we start off with methotrexate, unless there are any contraindications, and we can include other things such as sulfasalazine or leflunomide. When we move on to medications, if they don't respond, there are stronger medications such as biologics.
Okay, so if we go to the early treatment, because early treatment is essential, and you mentioned steroids, what steroids do you use? Different people use different amounts. So we often use prednisolone from 20 milligrams, and we reduce by 5 milligrams every week. So 4 weeks course in duration. Or methylprednisolone we can use intramuscularly, usually into the thigh, and that's 120 milligrams. Okay, and then when does biologics come into it?
We usually use biologics if they're severe enough, and we calculate severity by the number of joints affected, whether they've got raised CRP or not, and how they're feeling. And if they're not responding to conventional DMARDs such as methotrexate or leflunomide or sulfasalazine.
Okay. And then what would you like us to know as rehabilitation physicians about rheumatoid arthritis?
I suppose the important thing is, number one, to bear in mind how we diagnose it. The second thing is when to stop their disease-modifying agents or biologics. And we tend to ask to stop if they've got an infection, and also what to do when they're on their biologics. And you've got any concerns, you can contact us.
Great, thank you so much.